Good morning, everyone. Welcome to our first panel, which will be on artificial intelligence in early sepsis detection. For those of you on Pacific time, thank you again for taking the time to wake up bright and early to join us for what will be a very enlightening talk today on how AI is transforming early sepsis detection on a national scale and international scale. My name is Andrew Wong. I'm a clinician investigator at the University of Michigan with over 10 years experience in AI development for sepsis care and beyond. And I'll be moderating today's panel with the help of Mia Sheehan and Rick Janik, who I just want to shout out real quick, who have done really the heavy legwork in organizing today's panel session. Today, we have three excellent speakers on our panel, Scott, Vinny, and Rishi, each of you whom have extensive experience and expertise to share on the development, implementation, and deployment of sepsis prediction models. Our speakers will each be giving a 10-minute presentation on a core topic in AI for sepsis detection. In order to help things move along, we are planning to hold all questions and comments until the very end. So if a question does come up, please feel free to share it in the chat, put in the Q&A section, and we'll definitely address it at the very end once all the presentations are complete. So with that, I'd love to start off by introducing our first speaker, Scott Sherry. Scott Sherry is a board-certified physician assistant with over 20 years experience in trauma, critical care, and acute care surgery. Since 2022, Scott has served as the sepsis program manager at Oregon Health and Science University, where he leads initiatives in early recognition, management, and quality improvement for sepsis care. Today, Scott will be giving a presentation on his and others' experience in the implementation of early warning scores for sepsis at Oregon Health Science University. So, Scott, I will be passing over the hypothetical mic over to you now.
Thank you very much. Please let me know if there's any challenges with hearing me or any challenges with seeing the slides. I'd like to really start off by saying how humbled I am to be here among such an amazing panel of individuals, and I thank you for your time. And I really would like to just share with you our experience with implementing a early warning sepsis score at Oregon Health and Science University, a large quaternary care center. Okay, there we go. Sorry, having some challenges in moving. And really giving our experience. The objectives is this middle one is really talking about our successes, limitations, and lessons from a real world experience. And I don't have any conflicts. I do get some royalties, but it has nothing to do with this topic. And I feel that this is hopefully a very unbiased talk. We do have an experience at OHSU utilizing some of these predictive model scores in EPIC. We have utilized the EPIC Deterioration Index as one of our primary responses for our RRT team since 2018, wherein their team evaluates the DI score, and what they'll do is they will review the chart if they get an activation, and then respond or either connect with the nurses as appropriate. We had previous experience utilizing the EPIC early detection of sepsis, also known as version 1. We ended up turning this off in January of 2022. And if you remember, this was probably at the tail end of the pandemic. There was an exceptionally high sensitivity and a very low specificity, which is well known in the literature around this. We also had some early challenges of this work in terms of really ingraining this into our system. And after about 2.5 years of this, the pandemic, a lot of frustrations around pop-ups and alerts and just overall provider burnout, we made the decision to turn this off. We didn't really have an ingrained and connected workflow, and obviously the alert fatigue from these pop-ups were really weighing on a lot of individuals. Since that time, obviously, there's been some additional literature that has confirmed some of those biases towards the version 1, and we did not see any significant mortality changes. We monitored this over the course of the time since we've turned it off. Since then, obviously, EPIC has come up with a version 2, and we looked at this as trying to learn from our previous version 1, as well as trying to understand this version early on. What we ended up doing is we ended up implementing it into our system, pushing it into our EPIC instance, and we launched it into our EPIC system in February 2024. Our plan at this time to really mitigate some of the workflow issues was to pilot this model within a virtual ICU nursing care model, which was known as our virtual ICU. These nurses were there 24/7, and they were able to look at these alerts in the course of their other workflow during the course of the day and respond to it in a protocolized swim lane type of manner. We did some pre-work between February and April. We unfortunately had some delays to be able to implement the pilots, but this gave us some time to continue to review and monitor the performance as we work to finalize the pilot process with our virtual teams. We went live on April 8th, 2025. There were several PDSA cycles that were involved during the course of this time, and we gathered data and feedback from our virtual ICU nurses during the course of this pilot. Overall performance, we learned a lot of things, especially coming from an academic hospital, but we had almost 5,600 sepsis alerts that came to our virtual ICU team, which was a lot more than our our alerting that came through via our deterioration index. Each of these alerts represented about half of them were, about two patients per alert. Maybe we got that right. So about 2,800 individual patients were alerting these scores. What we had found through our work was that only about 321, or about 6%, resulted in an escalation from the virtual nurse to the clinical or bedside nurse to evaluate further sepsis concerns. This was, if you can imagine it, they see the score, they look at the chart, they have some questions or concerns based on what they see documented, and then they would reach out via secure chat or by telephone or Vocera to the bedside nurse and just either confirm or escalate any of those concerns. Of those alerts, about half of them ended up with some sort of recommendations, which I thought that was a very good part of this feedback, was that they were following our guidelines and our swim lanes to recommend to the nurses to initiate our nurse order sets for evaluation of sepsis, obtaining a lactate if there was that was a missing component of it, or initiating blood cultures. And in some instances, they were recommending frequent reassessments or reevaluations or escalations to the team or rapid response. Unfortunately, over the duration of our pilot, which was about 4 months, we did not have enough data to really permit process or outcome evaluation. Although we did see some signals to indicate some improvement, it was not enough duration to really give us that true credible performance evaluation. In terms of successes that we gained from this, is that we found that a proactive evaluation response from automated alerts by an experienced critical care nurse showed value. And I think there's other instances and experiences from other hospitals that really show similar value to this type of tiered response system. They were able to recognize deterioration and sepsis without over alerting the clinical teams with false alerts. And they provided actionable interventions and recommendations to these bedside nurses and really supported them. In many instances, there were nurses who are relatively new. We know that there was a large efflux of individuals during the pandemic, and many of these are newer nurses that were coming in and caring for patients, oftentimes at the worst possible times, off hours with little support. So overall, we did see some demonstrated qualitative impact in communication, the feeling of support, and as well as for improved response. We did have some limitations. From a technical standpoint, what we have learned since our evaluation as in the post phase is that we've learned and broken down that the EPIC's early detection of sepsis version 2, I'm curious about Dr. Wong's comments on some of this, is that it was really built and tested on the framework of sepsis 3 definition. By and large, I think very much support that concept. However, thinking about it, what they're really looking at is SOFA scoring change of 2 or more. What I do know is when we look at also our SOFA score and testing is that the respiratory component is often not collected. We do not obtain a PaO2 score, and that really requires that, and that is not a frequent. We could develop surrogates, but that's not the same SOFA score. We also found that neurological assessment was frequently inconsistent, and for SOFA scoring, that requires a Glasgow Coma scale, which is not routinely done in our institution across the entire enterprise, depending on your unit. Other things that we learned in the breaking apart the model was that it was tested against any culture data. So that could be something like a urine culture, a blood culture at any point in time. And so that was something that was really interesting. And then lastly, it was also tested against any antibiotics, both PO or IV, which really I think skewed some of the sensitivity in my sort of hypothesis. So we also had some operational issues. You can see here, this is the breakdown when you look at the factors contributing to the score. And one of the things I love is ICU nurses, they want to understand why these things are going off. And they would look at these scores and they would look at it and reflect of why is this patient scoring? Why is this score activating me to really look at this chart? And what we had seen is that there were several things is they were really unsure what's triggering and the alert or the change or why did this pop up. When they looked at it, they couldn't really make a good comprehension of that. And I think that built in some mistrust. And in my reading, that's also very much a contributor to distrust in these systems. Or when you think about how the alert, what is it that you're really trying to signal to the person that it has really changed to really get you that buy-in to really pay attention to the alert. We also had some operational issues with sustained elevations versus those who just spike and then come quickly back down. We learned that our cancer patients, because of their metabolic derangement, were really flagging off the charts as the highest responders to patients. And how can you really look at individuals and mitigate those alerts and not over alert certain areas without missing everyone else? And that was another concern was how do you silence these if you do have progressive things without ignoring the worsening conditions and then looking at other scoring systems or other alerting mechanisms to double back to those patients. In terms of our conclusions and our next steps, and I think I feel like I missed a slide. I may go back just to check. Hold on for 1 second. I did skip. Yep, I did it. There we go. I remember one thing there. So our conclusions and our next steps are, in retrospective, thinking about this process, is that this tool is only as effective as the process response and the systems that really surround it. And really building those robust systems up is just as important as the scoring system. And these scores are really not an endpoint of telling you they are or they are not. It's really a starting point or a situational awareness to really have that coordinated action. And as I think about this, this is no different than your warning light on your car telling you to check engine or check oil or your tire pressure. It's just really a starting point of what you're supposed to do. And as I frame this out as a construct, they really should prompt the early recognition of risk and indicators, and they should also help support the team in communicating these alerts and really having a shared understanding of what's going on. And obviously, timely escalation and activation of our resources. And I was thinking about it, it's a detection model that you still need that bedside to validate and reassess what is actually going on in the bedside. What are the inputs that are going on that are skewing the score, potentially skewing the score, or really seeing there, and having that assessment in context, and then figuring out how to really either do it from a local area to escalating communication within the care team, whether it's a more experienced individual or within the unit to really assure situational awareness. Not every one of these alerts need to have everybody rushing in, but really trying to do that building of what is really going on. And then from a system standpoint, there should be a larger observation of what's really going on in different units of who those individual sickest patients are and what's going on to really have a shared understanding to be able to dispatch resources such as the RRT in a more concentrated and constructive manner before deterioration occurs. So really looking at developing a responsive, adaptive, and aware system. And I acknowledge that we're in a large academic space, and it is vastly different than many of our other hospitals, but this is our academic experience.
Excellent. Thank you so much, Scott, for a fabulous presentation. It was really insightful to hear about your team's experience with implementing Epic's updated sepsis model and the many process factors that you had to consider at the time of clinical deployment. As you alluded to, I have many thoughts on Epic's use of sepsis 3 outcome labels, but I will follow my own rules and I will save these commentary for the end. Instead, I will have the pleasure of introducing our next speaker, Vininder Bains. Vinny has served as a clinical nurse specialist of critical care at St. Paul's Hospital for the past 9 years and is an adjunct professor at the University of British Columbia School of Nursing. Her 28-year nursing career includes 17 years as an ICU nurse, both as a direct care nurse as well as a clinical instructor for critical care nursing. Today, Vinny will be giving a presentation on the implementation of News and Muse in the Providence healthcare system and how to design effective clinical workflows to navigate sepsis prediction shortfalls. Vinny, the floor is yours.
Awesome. Thank you very much, and thank you for inviting me. I am just going to share my screen. This one, yes. And you guys can see that okay? Yeah, I see a nod. Okay, here we go. So I'm going to talking about news implementation at Providence Healthcare. Now, Providence Healthcare is actually a relatively larger organization, but I'm going to focus down to just two hospitals, and that's St. Paul's Hospital and Mount St. Joseph's Hospital. So Mount St. Joseph's Hospital is a 240-bed hospital. 100 of those beds are extended care, and there's 140 beds that are acute care. They also have a 6-bed HAU. And they have programs like medicine and geri medicine and surgery at Mount St. Joe. So it's a smaller hospital. St. Paul's currently is a 430-bed hospital in downtown Vancouver. All of those beds are acute care beds. It also has an intensive care, cardiac intensive care, cardiac surgery. We have implemented a critical care outreach team in 2019, which was wonderful. And they have a variety of programs: medicine, surgery, cardiac, renal, mental health. So it is a bigger hospital. So when I'm sharing data between these two hospitals, just wanted to give you a context of what we're looking at. I'm going to give you a brief history of our early days with early warning scores. So 2014 to 2019. So we initially implemented the 1997 version of the modified early warning score, which looks at your heart rate, blood pressure, respiratory rate, your neurological status, and your temperature, and kind of comes up with an aggregate score. This was back in the day when we were doing paper-based charting. And the way it was implemented unit by unit across all these different programs with individualized PDSA cycles. And as they were individualizing it, they modified the modified early warning score to suit their population in such ways like medicine included confusion, like a new onset of confusion and oxygen therapy into their modified early warning score. The cardiac floors tweaked the blood pressure to kind of match their patient population, and surgery added pain as an indicator when they implemented it. It was paper-based, but they were pretty successful at implementing it across those different programs, although all of those early warning scores were slightly different. It was also implemented primarily as a nursing tool. So it was a tool for nurses to help them understand when something was going wrong so they could escalate it to other people. It wasn't actually implemented amongst physicians. So if a nurse went up to a physician and said, hey, the Muse score is this, they may or may not know what they were talking about. So what we coach nurses to do is describe the vital signs in I am seeing these changes rather than saying I'm seeing a Muse score of this, which was, probably a miss. And it was used in nurse-to-nurse handover. So the expectation was well established that they were handing over the score between charge nurses and between nurses to the next shift. Evaluation is tricky when you're paper-based. It was always manual evaluation, but anecdotally, because it was utilized so frequently in the nurse-to-nurse communication, it was relatively well taken up. In 2019, we transitioned to electronic charting, which we were super excited about because the data that you can get and the things you can do, all the great promises that we got. We had to figure out how to get our paper-based Muse scores into the system. And because we were dealing with modified modified early warning scores. We had to kind of bring them in all into one alignment. And I think we were a little bit naive about some of the things that humans need to get right in order to get the system to work properly. So I don't think we designed our early warning score particularly well. We really wanted all vital signs to be done before it would score. So it wouldn't actually calculate for you unless you had all 5 vital signs written in. And some of the recommendations that popped up when you got an alert were, the language was vague. It was, we suggest, we recommend, we strongly recommend, but it wasn't very prescriptive. So it allowed a lot of interpretation. We also dove right into a pandemic right after we went into electronic charting. And it took a long time for our Muse reports to help us let us know how we're doing to be built because of all of those delays. And so we really kind of broke our early warning score. Our early Muse utilization went down to about 9%. So we had a lot of things to fix. In the fall of 2022, after much consultation, we opted to scrap the Muse and switch to News 2, which was, the latest version, which at that time was the 2017 version. And it solved a lot of problems for us. For one thing, some of the elements that we were modifying in the modified early warning score were incorporated into News 2. So including new confusion was incorporated, including oxygen therapy in the total score was incorporated into News 2, which suited our teams better. There's still things that people would still want to tweak, and I argue that all the time, but the other thing we really liked about the News 2 is it was really designed for an electronic system. So in the NHS, they published additional guidance about how you want to design it in an electronic system so it works well. And we followed this guidance to a T. It's very well detailed, and I highly recommend taking a look at it. It was incredibly useful. The other great strength of the News 2 that we didn't really have with Muse is the escalation guide. The QR code will link you to our guideline for News 2, so you'll have a better picture of this. But what I really loved about the News 2 is when you have a particular score, it's very prescriptive of what they want nurses to do. So it doesn't say increase the frequency of vital signs. It says you're doing vital signs every 4 to 6 hours, or you're doing vital signs every hour. It's much more direct. And so clinicians have a much clearer idea of what they're supposed to do when they get these elevated scores. So now that we've implemented a better early warning score that worked well in an electronic system, we wanted to measure how well we're doing. And so there was a lot of metrics, but we prioritized the first 3 reports that we wanted to create, really looked at, are we doing it right? So the first report we built is news on admission. Is news happening within 2 hours of arriving on the patient floor? The goal we wanted to have was 80%. Of all the patients who were admitted, we wanted to have at least 80% of the patients getting a news score within 2 hours of arriving on the floor. We wanted to see that a news is being completed on a daily basis. So we wanted to see, is news being done at least twice? Patients get ordered a variety of different vital signs depending on how sick they are, but we figured for the majority of hospitalized patients, at least twice a day. And our goal was 80% for that as well. And the third thing we wanted to know is, like, if you get an elevated score, what are people doing? Are they actually doing something with those scores, or are they just doing the same thing? So we wanted to see where vital signs were being increased, where providers were being notified, and if you were at St. Paul's, was the CCOT team getting involved? So those were the first 3 reports we had. And I want you to recall that when we were in Muse days, our old early warning, so we were only at 9%. The day we flipped to Muse 2 without doing any additional onboarding or education, it doubled. We went up to 18%. Long way from where we wanted to go, but that I think illustrates that good design really drives utilization of the tool, and we had better design with News 2. So that was reassuring. At MSJ, news was happening within 2 hours of admission for 45% of the patient population, and 3% of the patient population, news was not being done at all. St. Paul's, and then this was from April to September in 2023 after we had just shifted over. At St. Paul's, the numbers were a bit worse. It's a bigger hospital, and you have to convince a lot more people to do something differently. So we were sitting at 26%, and 11% of the times news was not being done. And so I shared this information with. The other thing I wanted before I go into that is news being done on a daily basis? At MSJ, just as they switched over, it was news was being done 35% of the time at MSJ. And it was being done at least once 70% of the time, but twice a day was only about 45% at MSJ. And St. Paul's, just a smidge worse, bigger hospital, harder to make change there. And did that mean that they were actually doing, like, are they not checking these patients? What's going on here? So I wanted to know, well, there's a news score, but what about vital signs? Are vital signs being done? And actually, staff are doing a lot of vital signs. 90% of the time you're doing it at least once, 80% of the time for heart rate, you're doing it at least twice, but a lot of times you're doing way more frequently than that. And that was true not just of your heart rate, but really all of your vital signs. So your heart rate, your respiratory rate, people did that a lot. So it's not a problem that they weren't checking these patients, they weren't doing vital signs, they just weren't translating those vital signs into an actual news score that would pop up an alert to action them to do something. So that was reassuring. So when I presented this data to both St. Paul's and MSJ, I had an incredible team of educators at MSJ who really wanted to champion this. So they initiated a quality improvement project. And like, quantitative data is great. It really does help you know what is happening, but why things are happening, you really need to have intentional inquiry. And so these educators, they really dug into what was going on. They followed up with individuals saying, explain to me what you're doing and what your thinking process is behind this. They reiterated the value of the new score and what it could potentially do to help keep patients safer and how important it was. The charge nurses started to really reiterate that I want to see a new score on report, so make sure you give that to me. So that really using the language on a regular basis. They started to include it into new staff orientation. I think we had trained everybody, but when we onboard new staff, we wanted to make sure they really understood that this was important to us. And what we learned, and this was kind of funny, is while we taught all of our staff, the vast majority of vital signs were being done by students, and students weren't being exposed to news education. So, so that was something that we really had to prioritize with our nursing schools. And then we really had to bring MDs back into the conversation. So when they talk about a news score, they were using that same language and they understood what we meant when we were saying, oh, the news is 5, we got to do something. And what is really exciting to see is that, our baseline at MSJ was 45%. It didn't change at St. Paul's because they hadn't really gone through the same work, but it did start to change at MSJ. And I think that really speaks to that person-to-person education and inquiry that our educators were doing. They really committed to that. And that was done from April to November. By December, they were hitting their target. So they really did manage to achieve our goal of at least within 2 hours, a news score was being done. And similarly, is it being done daily? You can see right here when education really started to make a change in people's behavior. And this data goes until the November 2023, but by December, they were hitting their target. And you can see how abruptly that change happened at MSJ, which was brilliant, loved it. And then the final question is so did it change anybody's behavior? Did they started to do anything? And so we looked at, pre-implementation and post-implementation. How many news alerts were you actually getting? In August, it was 126 alerts. In December, when they had made this change, it was 224 alerts. And interestingly, they weren't getting any more high-risk alerts. In August, it was 23. In December, it was 34. So a little bit more, but not a ton more. But what they were getting was a lot more medium and low risk alerts. So I think when we asked the educators, what's going on, what's driving this, I think people recognized when things were going wrong, and then they would do a news score when they knew things were going wrong. And so the high risk alerts didn't actually increase that much, but the medium and low risk alerts did start to increase when they started to do news more concurrently. When a news alert did pop up, people did do stuff. So they did increase the frequency of vital signs, but because you're getting more alerts when you're doing news more consistently, that increase happened 140 times rather than 49 times. They were notifying somebody else, whether that was their charge nurse or someone else. And a lot of times they were notifying their providers. And because you're getting more medium and low risk alerts, you have more time to intervene and potentially change patients' outcomes because of that. So that was really wonderful to see. It was really nice to see that the alert system changed human behavior in a way that made sense, that would make things safer for patients. And sharing that information back to the team really reinforces the reason why a news is such an important part of patient safety.
That's awesome. Thank you so much, Vinny, for this insightful presentation. It was really interesting to hear about kind of the design issues that you had around Muse initially and how you really managed to navigate this with the implementation of Muse. So super exciting. All right. Well, I have the pleasure to introducing our final speaker today. This is Dr. Rishi Kamaleswaran. I hope I pronounced that right and didn't butcher it too badly. Dr. Kamaleswaran is an associate professor at the Department of Surgery and Department of Anesthesiology at Duke University School of Medicine, with secondary appointments in electrical engineering and biomedical engineering in the Pratt School of Engineering. His current research interests include severe sepsis detection and multi-organ dysfunction syndrome. His contributions in the area include AI and machine learning model infrastructure, clinical big data, real-time event stream processing, data analysis and information systems design, and much more. Today, Dr. Kamaleswaran will be presenting on a critically important topic, which is the use of AI and other technologies for sepsis detection in low resource settings and how this needs to be considered in international benchmarking and external validation. So Rishi, the floor is yours.
Thank you so much, Andrew, and it's a pleasure to be here. Thank you for the invitation. So my disclosures, I have some funding from NIH and other federal agencies. So as many have discussed so nicely in the last few presentations, sepsis is a major problem that we are having globally. Worldwide, it's been responsible for up to 1 in 5 deaths. In the United States, it's estimated to be responsible for up to 1 in 3 hospital deaths. However, it's a very heterogeneous syndrome, and this requires or this results in accurate and early identification, really difficult. So I want to characterize these, as you've seen in the prior slides, what is happening and why is it so difficult? So this here is an illustration of disease severity and decompensation as it manifests in patients who are septic. So, let's say you take a grandma from a nursing home. She's somewhat healthy, but starts to develop a fever, gets a little tachycardic, tachypnic, and then there's a region of uncertainty where continuous deterioration occurs, but it's not quite clinically significant, so no action is actually attended until at point where there is visible signs of distress, and she gets called for an ambulance to transfer to the ED. At this point, things become very complicated. There's resuscitation that's attempted in the ED, and further admissions to the ICU where required. All of these things reflect an emerging, evolving process that is really difficult for the human eye to detect, especially when it's occurring at a very subtle and complex way. And so where we're positioning the use of artificial intelligence is better to better estimate these subtle changes that occur over a large variety of different physiology, to make it easier for us to capture that early state. So what are we doing? In high resource setting, we are really throwing everything. We're throwing the kitchen sink and more at the problem. We have huge amount of compliance bundles. We have a massive EHR data that's being recorded hourly or every 2 hours. And in some cases, we're monitoring these patients on ECGs, on blood pressure cuffs, and also collecting some biological data to study potentially what is going on at a later stage. We have an abundance of data, but even amongst this abundance of data, because the condition is elusive, we are oftentimes playing catch up, and so we're finding things after they've occurred. But the challenge is, well, what if, we do find something, and what if we do develop a really nice, elegant solution like an EHR alert, but it requires 50 different variables? How reliable and how feasible is it to translate these into low resource or even frugal settings? And this is a major challenge, especially as we now move towards more advanced technologies like large language models and transformer architectures. We don't have these cutting edge GPUs in the field, in areas where there's low resources, and so oftentimes the solutions may be compromise in the expressiveness of that underlying architecture. So one of the most frequent works that people do to make, even for instance in our current environment, where we want to run a large language model on our local work machines rather than on cloud-based infrastructure, we oftentimes quantize it. We cut off the decimal points and we try to round it up so we can run it on our local machines. But this results in major loss of specificity, and that's not necessarily the answer, especially as we move to apply these band-aids. I want to highlight a specific exercise that we ran over the last year and a half or so. It was the 2024 Pediatric Data Challenge, where we had teams from 43 different countries come together and analyze data that was collected from hospitals in low and middle income countries, with the intent of actually making them widely usable and interpretable. What we found were very encouraging initiatives, especially from folks that actually came from those low and middle income countries and were really understanding the potential applications of those tools into their own hospitals. We had in our final leaderboard teams that came across different countries that were really showing that they could rise to the challenge and provide solutions that were interpretable and widely accessible. So the top ranked team came from AIMS Cameroon, whereas we had other teams from the United States, from the UK, from Korea, Pakistan, Switzerland, and so on. And what was interesting about our approach is that we deliberately thought about a number of metrics. So we had things like calibration. We were looking at net benefit. We're looking at F1. All of these are more subtle metrics that really captured performance across a wide range. And what we're showing here is that models were really performing all across the spectrum, especially as we look at the basic benchmarks. So you had models, for instance, that were performing on the lower AUCs, but achieving relatively poor AUPRC. At the same time, you had models that were achieving excellent AUCs, but were having modest precision, or what we call positive predictive rate in these cases. And you had models that were balancing the two and really trying to develop approaches that were not only very accurate, but also performed with a low amount of false positives. So these were examples, real world examples of what could come if we could design and develop our validation approaches in in a way that was thoughtful rather than just trying to chase after numbers. So I wanted to conclude just by eliciting three major themes that I think will define our direction going forward. One is we as a community must develop diverse data sets. It is important for us to not only capture data from very high resource environments and academic medical centers, but also go to the community, go to areas where there's less resources so that our models can be trained to be truly generalizable. We don't want models that work only for us at a certain time frame, because eventually, as medicine and practices change, there are new new labs and new frequencies of vital signs that are recorded. Those models are not going to perform as robustly. The other aspect is decentralized models. So we talked about hospital of the future. I mean, we talk about it frequently that more and more we want we want to see a decentralization of care, where primary care, and even in many cases to this day, you're zooming in to see your primary care provider from home, and we expect this to go further. So how does sepsis models really allow us to contribute to that future vision of a decentralized care model? And then the final point is integrated intelligence. And if our ultimate goal is to fuse all these different very complex metrics into our decision making, we have to do it in a fair and integrated manner. You don't want to, you don't, for instance, take a really smart clinician and cover their eyes and close their ears and then push them into a room and and ask them to make a decision as to whether the patient has sepsis. In similar ways, we don't want to expect our models to be limited by what they can see and what they can perceive, and ask them to do something that humans have a hard time doing. So we have to start thinking about multimodal integration. We have to move from just our simple EHR data to other things. And I think that's the direction that we want to go. So thank you again for your thoughts. I want to just acknowledge some of our funders and a fantastic group of lab that I'm fortunate to lead. Thank you.
Thanks so much, Rishi, for highlighting this critically important topic, and really expanding our thinking of how do we apply AI to broader communities and populations. Excellent. So wonderful. I think we'll move on now to the Q&A session. We do have several questions from the audience. So maybe I'll start here. So for Vinny, there was a question about whether you captured any data on changes in patient outcomes after implementation.
Yeah, so it's a bit tricky because MSJ is a small hospital and they don't have code blues that often. So what we hope to see is when you get early intervention, patients should not deteriorate to requiring CPR. The thing is, they don't have that many codes there to begin with, so I have to collect data for a long time before I see a difference in that. My next step is that, get this implemented at St. Paul's. And with St. Paul's, we have a CCOT team. We have a lot of robust data around CCOT that I'm already routinely collecting. So I'm hoping to see that the wards ICU patient population outcomes, we'll be able to see a decrease in hospital mortality and a decrease in code blues requiring CPR in non-critical care areas. So it's in the works. It's just MSJ is a great place to implement stuff. It's not a great place to do statistical analysis because it's small and it's variable and you don't get the numbers you need.
Thanks so much, Vinny. Another question that came up in the Teams chat, it looks like here, is a question for everyone. And the question was implementation of learning AI systems. So the question was, how has anyone, rather, compared AI models that learn the patient's physiology over time versus applying an AI model that's learned from a population beforehand? Does anyone have any expertise or experience in this?
So I can maybe start, Andrew. I think learning health systems is a great concept in theory, but it really requires, as I think Scott had put in his presentation, that it's only as good as a process. If you have really nice AI algorithms that are developed to pick up and predict sepsis, for instance, if no one is looking at it, what difference does it make? And if no one tells you what's wrong with it, how do you improve it? So I think that is a huge opportunity for us to really think about this as a process and as a learning health system, and not just isolated. This is what IT has pushed on us. This is what you know. The new thing that we have to solve. Let's move on with the rest of our lives after. So I do agree that that's a fantastic opportunity.
Any thoughts, Scott or Vinny?
Oh, no.
I think my only thought is that it's great to have systems that alert and identify things, but we need to change. But those alerts, those notifications need to change human behavior, and so humans need to understand why this thing is alerting. They need to buy into that it's important, and it actually has to have value in what they do. I think we spend a lot of time creating really great tools, but if we don't implement investigating what humans do with those tools and how they think around them, then we're going to be stuck with a system that does great things and you can do great statistics with, but may not change patient outcomes. That's where the money is patient outcomes, right?
I absolutely agree. I think this was a theme that kind of spanned across all three talks, and really emphasizing what does implementation and deployment really look like when it comes to day-to-day actual use in the clinical setting, right? And I think that a lot of the AI field in general, not just in sepsis, has been pushed toward this direction of where are the prospective clinical trials, right? Where is the actual evidence that providers are using it, that patients are benefiting? Because it's easy to actually build models these days. You can build models that they're a dime a dozen, but if no one is using it, as Rishi mentioned, and no one is looking at it, what is the actual impact? Are you just throwing money into a pit, building models that aren't going to be used? So super important. Thanks both Rishi and Vinny for mentioning that. Excellent. We do have a question, a little bit more of a methodologic question. Is there a best practice with what to do when handling missing data in scoring systems?
I'll be happy to chime on that because I think this is critical. So the way to answer that question is, what would you do if you were a human sitting there and you were, you have to make a decision and the lactate value is not there? What do you do? So try to really think about that from a real world implementation standpoint. The best practices, the guidance suggests, refer to population median, not mean, and refer to things like time gaps. So just only impute missing value for a certain amount of time. Like they recommend 12 hours for vitals and 32 hours for labs, and never backfill. Don't try to take a current value and then impute it going backwards, because that means the models can now see what happened in the future. And that's breaking causal constraints and causal violations. So basically, a lot of really nice things, and we're not seeing that being done as often as it should in the model development communities. So great question, and happy to chat more if you have further follow-up.
In more of a real world application, I think, when I think of missing data, it's just parts of the chart that aren't there. And how do you signal back to the clinician that your data is either erroneous or it's missing, and it's an important part of that aspect of the care, whether it's a level of consciousness change. You really need to have that good data input, and really there has to be a signal back to the clinician. You're missing the vital sign, you're missing the respiratory rate, or you're missing this piece of data, which may either feed into a active model or the NEWS2 scoring system. If those things are erroneous, you get false flags as well.
Absolutely. Thank you, Scott and Rishi, both. We have a couple of questions for Vinny specifically. One question was, hi, Vinny, can you share your strategy for engaging the MRP with news, as well as can you tell us more about your team's strategy to improve the experience of point of care nurses?
Okay, so engaging with physicians, always my favorite topic. I think one is that we needed to make the information, well, we had to socialize the language. It needed to be used on a regular basis. We had to start inviting physicians onto our news quality improvement team. And they have a lot of demands on their time, but if you can get a physician onto your team to really help champion it amongst their teams, it helps quite a bit. I think also with the the influx of new residents, news and early warning scores are becoming more socialized amongst medical education, so it's less unfamiliar now than it was back when we first started this work. I also think there's value. You have to, the same thing we do for nurses, we have to show that there's value for the physicians as well. So one of the things that we did was we socialized. We had in Cerner, that's our system that we use. We have a results review section, and we created a results review page that was just for early warning scores and sepsis and CCOT. So it summarized the vital signs and the news scores and the provider notifications that happened with that all on one page. So the information was more useful for them. So I think you have to spend a lot of time really figuring out why it's important to them and make that information available to them in a way that makes sense to them. If you don't do that, then you're not going to get much. And then what was the second part of the question? Improving the experience of point of care nurses. Like, I cannot emphasize what our educators do. Like, it is really, now educators are really good at understanding their staff, understanding how they think, identifying barriers, and it's sometimes really simple as like finding out the students do all the vital signs. Like, we were like, what? We didn't even think of educating the nursing students, but that's where the breakdown was.
Wonderful. Thanks so much for sharing your experience. That really point of care emphasis and working with people is really important when implementing these models. I think that's all the questions we have from the chat. And if anyone else has additional questions, feel free to share. I do have a couple of questions that I'm curious about after listening to all your talks. And the first one is the implementation of these models clearly requires a lot of knowledge and expertise, right? All of you are kind of expert panels that represent your institutions. But many institutions, especially kind of low resource health systems that were highlighted in Rishi's talk, may not have the necessary expert personnel or those governance structures necessary to effectively deploy and monitor these tools over time. So what do we do as a field and as a society to really ensure that novel technology like AI is really closing the healthcare disparity gap rather than widening it? Is there anything we can do, or perhaps we're just out of luck?
Yeah. I mean, I can tell you the challenge of trying to figure out good metrics is really, really hard. And trying to figure out good design when you're not an informatics expert is hard. So the more that we can do to publish and make the stuff available, I have to commend what the UK did at publishing the guidance for the news too. That was our Bible when we were implementing it, and it made a big difference about how. So steal shamelessly and share broadly as much as possible.
I'd like to at least say for the Oregon, we have some experience not specific towards sepsis, but during the pandemic, there was a shared model of resource allocation. Unfortunately, the state of Oregon does not have quite as many hospitals as other major cities. So you can imagine in rural Oregon, having the right patients into the right place was very challenging. So they developed a center to be able to communicate who had the right bed, who had the who had the right area, and doing some prediction modeling associated with that. And I'm curious how that could also be in regional areas. Is how do you link up, like you have 3 septic patients in your small community hospital, you need to redistribute or get support to that hospital. I think we're going to have, as Rishi mentioned, a lot of challenges coming up with how to do getting the right resources to the people, and you may have to think outside of the box with coordinated approach or e-consults or those type of things to help stabilize or recognize deterioration and sepsis outside of your institution, if nothing else, to keep them back in their communities, because we know there's a lot of challenges with sending a person to a larger academic hospital, and the financial situations revolving around that.
Now, I'll just quickly add that, I think we should also not forget the elephant in the room, right? So a lot of our frontline staff are, sometimes using ChatGPT and other large language models to come up with summaries and even sometimes guidelines, like what should be done in this case. So like Vinny and Scott said, I think we should always be looking for opportunities to leverage resources and use them in a judicial, you know, constrained manner. But I think we should not lag behind, especially where expertise may be available in very atypical ways. I think there needs to be some way to do this because you know, we should always be thinking about the future.
Absolutely. Thank you all. And David also had a great comment in the chat. I wonder if we can include known risk factors such as unstable housing into models to start reducing bias in models. And even beyond that, and perhaps extending our kind of inclusivity in our data sets, right? Making sure that our data sets are representative. Because we all know that a lot of data sets that are being used to build these tools are biased toward high resource settings. So all very good. Yep, so just quick shout out by Rick, as well as you can also include SDOH and housing and other factors as well. Yeah. One last question, I think, and then I think we'll be at time, but I'm very curious. You all actually have a ton of expertise in the implementation and deployment of these sepsis models. And as leaders in this space, I was wondering if there were one or two key factors or items that you really wish model developers in the future would really consider when designing and training future versions of these tools. Because I think that oftentimes there's a disconnect between who's actually using these tools and deploying these tools and who's building them. So I was wondering if like any of you had feedback or like wishes that you kind of could tell the model developers, if you're not the ones developing the models, like what should they be thinking about when building these tools?
I think having those models or what they're training under really clear is one part, and that was an uncovering that I'd realized in our work. And then on the other side is I think from the end user, helping to really explain why that model is alerting at that particular time is really helpful, because I found, and this is one of the great things with the virtual ICU nurses, is every one of them was like, I don't understand why this person is alerting. And that really gave a lot of good feedback and perspective, that if you can't explain that to a seasoned ICU nurse, why that person is really alerting in a broad sense, you're going to miss the message when you do need the people and that actually really do have the issue that you really do need the intervention on quickly.
I think also the other thing to remember is that this is not a sprint, but a marathon. And it's going to require a lot of back and forth and a lot of
I think your
Rishi, I think
audio
your
cut out.
audio might have cut out there. I'm not sure. I think maybe the universe has told us we are at time, unfortunately. So, Rishi, if you're able to connect back, I'd love for you to finish your thought.
Yeah, I know. Just saying, bring everyone along. Yeah, that's great. Yeah.
Excellent. Wonderful. All right. Well, I think we're at time. So I'm going to pass it back to David. Thank you once again to Rishi, Scott, Vinny for all your expertise, sharing your experience, and really contributing. I think we've learned a lot about what it really means to deploy these models in the real world. So thank you again. And thank you for David and everyone else at the Sepsis Forum.